So for those who don't know me, my name is Derek Landis. I'm the telehealth coordinator with the Missouri Rural Health Association. Really excited about this webinar. When I first met the team over at T Squared, I'm gonna be honest, I think y'all were great to meet with, really excited to work together, excited for your presentation. I'll just do a quick introduction and let them take it from there. So first, we have Mina, and Mina co-founded T Squared in 2018 after many years of working on the financial side of the healthcare industry and seeing the critical need for more specialty access in small and rural hospitals. Before that, she managed a multi-billion-dollar portfolio of healthcare businesses for many years, including hospitals and health tech companies. At both Royce and Associates and Wiper Capital, Mina started her career as a consultant at Bain and Company, working in both the San Francisco and New York offices. She earned her BA in International Relations/Computer Sciences with honors at Stanford University, and her PhIL in Technology Policy at Judge Business School at Cambridge University, where she was a Gates Scholar. Anand is the Chief Product Officer and co-founder of T Squared and the visionary whose mission is to connect medical facilities, no matter where they are, to specialists they need to deliver the best patient care. Driven by the opportunity to use technology to solve medical access problems for places like his rural hometown, he is leading the team to building the first multi-specialty turnkey platform for inpatient specialty teleconsults that is simple and cost-effective to set up and fits in seamlessly to existing clinical workflows. Before T Squared, he had 15 plus years of experience in executive roles in strategy, operations, and finance. Most recently, Anand was the senior director at LinkedIn/Microsoft, where he led a number of key strategic initiatives, including determining LinkedIn's approach to healthcare. That's really impressive. Prior to LinkedIn/Microsoft, Anand was the COO/CFO of another tech business that he led to a successful sale, and also led key teams at KKR and Bain and Company. Anand has a BSE degree in biomedical engineering and a BS in economics from Duke University, where he graduated magna cum laude. And with that, I will pass it over to y'all.
Thank you so much, Derek. We appreciate the warm intro and warm welcome. We're super excited to be here today and speaking with all of you, whether you're hearing us live or you're hearing us later on the recorded session. Just so you know, we will be sending out the slides later in PDF format. So feel free to take whatever notes you want, but just know that you will have the slides to refer to later if interested. And just so we're all on the same page, what I'm going to do today is I'm going to start with a quick overview and scene set of where we are with the current specialist access problem in the country, especially in Missouri, and then what that presents as an opportunity to help solve the problems that this creates, especially in the era of COVID. This has been drilled home, and we're just going to kind of make sure we're all talking about the same problem and identify that same opportunity at each of our hospitals. Then we'll go into a little bit more about the specific value proposition for providing on-demand remote specialty access at your hospitals, and then go into further details on how to do that with best practices and reimbursement trends. So Anand, if you could move to the first slide. Just as Derek's given a great intro, so I won't spend a lot of time here, but I did want to emphasize that the reason we got into this, Anand and I and the rest of the team, is because we actually come from small towns across America. I'm from the West Coast, Anand's from the East Coast, but we grew up where we are the black sheep of our families, and we are the only ones that are not physicians. So we grew up our whole lives hearing from our mom, our dad, our aunts and uncles, now our siblings, about how I have to transfer so-and-so today because I couldn't get the hematologist for 3 months. I had to transfer so-and-so today because I couldn't get the cardiologist till Friday. Always issues where it was a problem of, it was not a problem of resources, it was a problem of specialist access. And so we thought that we think, and we know that we have found a better way to make that happen. And we know that there is a better way to make it happen for all the hospitals that are facing a similar situation. So on. Just to put it in context, specialty consults are required in over a quarter of inpatient admissions. And this is probably actually lowballing it a little bit just because so many hospitalists and ED physicians today, just because of the dearth of specialists, are working at the top of their license and doing fantastic work, quite frankly, in very difficult situations, where they're handling things that they not necessarily thought they would handle when they went into that particular line, whether it's emergency medicine or internal medicine. So usually when you're calling for a consult on an inpatient basis, and when I say inpatient here, I'm going to be referring to both the ED setting as well as the actual admitted inpatient setting that we traditionally think of. So basically in the hospital setting, when you're calling for a specialty consult, it's for something that's you need a little bit of extra help and support on. So whether that's infectious disease, whether that's cardiology, someone's come in, or neurology, someone's come in with a suspected stroke. Obviously, we've seen a lot specifically with COVID, with infectious disease and pulmonology, with COVID protocols, identifying patients that have come in, treating patients that have come in with that. And so this is when a case is too complex and they want to have a little extra advice and expertise on their side and have someone that can help them develop the appropriate treatment plan, appropriate differential to make sure they're diagnosing correctly on that first time and treating with the most advanced protocols recommended today. So if we go into where we are on the next slide, we'll see that uh, we'll see that while we need a lot of inpatient consults, over 65% of US hospitals don't have adequate access to these specialists. So the US today has over 6,000 individual hospitals. Over 3,300 of them have a critical specialist shortage. And that's defined as having 3 or more key specialties underserved or not served at all. And what that means is that leads to over 1 million unnecessary interfacility transfers annually. And just to pause there for a second, unnecessary means that it wasn't because there was a lack of resources at the home facility. The MRI, the CT, the formulary, everything else needed to treat that patient was there. The only thing missing was the access to the specialist to help determine that appropriate treatment plan and manage that patient's care. So, in addition, that leads to much lower bed utilization than anybody would like. We know with the high fixed costs of hospitals, maximizing that bed utilization is key. Getting that number up to the 60s and higher is ideal. Unfortunately, when you have situations where you're unable to keep that patient, have to transfer them out just because you're uncomfortable with that specialized care required, that usually tends to 40% or below bed utilization. And then, of course, financially, what that means is over $17 billion in annual revenue lost because of this, because of these transfers and the lost DRG payments and all the ancillary revenues that then get sent out to the tertiary care centers. And once that patient leaves, maybe they don't ever come back, or the follow-up care isn't captured. And so there's a lot of negative repercussions that keep echoing around due to that. If we go to the next slide, we'll see what this means for Missouri in specific. Probably all of you are very familiar with how it lays out in terms of where everybody is. But if you look at on this map here, the green counties that are shown are the ones that have a pretty high concentration of specialists. And of course, those are concentrated on the urban academic counties, right? So no surprise there. But look at what that means for the rest of the state. Even though they have a much greater population than those green counties, and they have dramatically higher, to almost 2.5 times the number of hospitals, they have almost 150, more than 150% less of the specialists for this region, right? So what that means is all the specialists are in these green counties. Everybody, there's a huge population, huge demand, huge hospital concentration in the gray areas, and the specialists just aren't there to serve them. So there's a lot of transfers happening from the gray to the green, and that's definitely an area that can be helped. We'll see on the next slide here exactly what we learned during COVID. So specifically, and again, I'm sure you saw this all personally yourselves. COVID highlighted exactly what it meant to have a specialist shortage. So the rural hospitals with specialty access, whether that was in person or whether that was through telespecialty, were much better able to meet the challenges. So the large gaps, specifically in infectious disease and pulmonology, but since COVID is a multi-systemic disease, we saw it with GI, we saw it with cardiology, we saw it with nephrology, saw it across the board. The inability of managing those patients and needing to transfer them out became a real problem because, as we saw with COVID, everybody was impacted. So the transfer pipeline, for example, wasn't able to function as it normally did. So instead of managing the patient to the point where then they would then transfer them away, they weren't able to transfer them out to a higher level of care and had to somehow find a way to treat them locally and unexpectedly, right? And so no one wants to handle that when they could potentially either have that treatment available on site or send them to a place where they actually could get that bed and could get that treatment. So with the telehealth coverage, though, the hospitals that had it or had that remote specialty access, they were able to get guidance on things like ventilation management, the newest protocols for monoclonal antibodies, setting up the specific protocols for COVID patients, and probably most importantly, treating and clearing patients for discharge faster to open up more beds, so that they weren't sitting there with, stacking the ED with 2 or 3 deep in terms of beds because they were just so impacted with patients they couldn't otherwise clear out. So the opportunity, so that's the cost, that's the problem, and that's especially what COVID drove home to us: the fact that if you don't have remote specialty access, not only are you losing a lot in terms of transfers, in terms of money, in terms of bed utilization, but when a pandemic or a black swan event like this comes around, it's really going to drive it home and make it that much more painful. The benefit here, though, the opportunity, is that 60 to 80% of these interhospital transfers were found to be preventable with remote specialist coverage. And the key here is that that's without any additional resource investment. I just want to emphasize that for a second. Through a study done with UCSF, we found that over 2/3 of these types of transfers to a higher level of care were addressable by E&M consults. Again, non-procedure. There's always going to be some transfers. You're always going to have a stent that's required, or thrombectomy, or some kind of GI procedure, etc. So there's going to be some transfers that have to happen because the patient needs a procedure that is unable to be provided on site. But for the rest of them, especially in the areas of cardiology, neurology, pulmonology, ID, etc., those are able to be treated if you have access to that specialist, and that specialist can help guide the patient's care, guide the treatment plan, guide day-to-day management with that remote access, and with remote access both to the patient's chart, to the patient, and to the medical staff on site. So that's a fantastic opportunity, a fantastic finding that shows that even if the specialists aren't there, they can still be there for you. So let's go to see what that could mean in terms of what does that mean for a hospital as a value proposition. If you could get that remote specialist care, what would it mean to you financially? What could it mean to you clinically? So first things first, most people, when you think of telemedicine, you think of, oh, I have a Telestroke service. I have it, I'm done. Or maybe you think I have Telepsych, right? They don't think beyond Telestroke, and that's fair. Telestroke has been around since the late 1990s. It's had about 20 years to mature. So it makes sense that everybody's heard of it and most people have it. However, if you look at how the telestroke model works versus telespecialty, and telespecialty covers everything else, including general inpatient neurorounding, not just the acute stroke management, um, it's applicable on a much broader range. It's easier to implement. It's easier to get reimbursed, and there is just as much of a financial impact, potentially if not more, because of the number of patients that are impacted. So for telestroke, a patient comes in with an acute stroke, you call the telestroke service, and then they manage that patient, keep them there. So exact same concept, exact same principle, exact same value proposition. There's fewer of them a year. It's very difficult to implement, very expensive to implement, because you do need special carts, special equipment to manage an acute stroke patient on site and keep them there locally. For the telespecial, and the ability to get reimbursed there is relatively low, but the value is really high because you're able to keep that patient and keep the long-term care and the ancillary revenues local and on site. Telespecialty, similarly, it's about the same value in terms of saving that patient transfer, but there's way more of them. So instead of just an acute stroke patient, you're talking about cardiology patients, you're talking about subacute stroke management, you're talking about all the infectious disease, osteomyelitis, bacteremias. You can kind of expand that field across the board. For pulmonology, you can talk about managing patients with COPD, or you can talk about managing patients with congestive heart failure. All of these, we've actually seen patients with infectious disease get necrotizing fasciitis. So there's so many more patients you can touch and you can treat, and you can keep local with a telespecialty consult, broadening up the opportunities to keep your patients local, to treat your community at a higher level of care across the board. And the beauty of that is that it's much easier to implement, and it's much easier to get reimbursed with still having that same impact on saving the transfer and getting the benefits on that end. So if we go to that next slide, we can see exactly what that means. What does it mean when you're saving that transfer? So putting real dollars to cents on this. So each patient helped on a telespecialty consult, similar to Telestroke, impacts the metrics that are top of mind for hospital CEOs. So within months of launch, So you reduce the unnecessary transfers. So remember, some will always happen because you need a procedure, but for everybody else, that 2/3 of transfers that are happening unnecessarily, that's about $15,000 each patient that's going out the door every time you transfer that patient. So you can keep that patient and you can keep that money and you can keep the general economy of that of the hospital ecosystem going by saving that unnecessary transfer. In addition, we talked about the impacts to bed utilization by being able to keep more patients locally. Um, get a higher bundled payment and ancillary revenues. And this is because when you treat a more complex patient with these specialty consults, you're treating patients that otherwise would have been transferred out that probably would have been a level 4 or 5. And as you're treating more level 4s and 5s, you're able to increase the CMI of the hospital overall. So you're able to actually increase the billing rate and the billing value of all of patients at the hospital, not just the ones that you were called for a consult. And that's actually fantastic in terms of increasing the ability of the hospital to command a higher reimbursement rate across the board and get higher bundled payments and ancillary revenue across the board. It's also a great, fantastic way to decrease length of stay. So most patients that do see a specialist are discharged much faster than the mean length of stay from CMS because that diagnosis, that treatment plan is arrived at much faster and implemented much faster. And of course, and we can't emphasize this last part enough, you get the improved confidence and comfort of the attending physicians and local medical staff, nursing staff, et cetera. We've heard so many comments across the board how grateful they are and how much they love working with the remote specialist because they feel more comfortable and because they feel very so happy to be able to keep their patients. No one likes to transfer a patient away. And the fact that they have an extra resource, a tool in their tool belt, if you will, to be able to keep their patients makes them feel really good. I'm going to close here with just a couple quick case studies. To give you a sense of how this could work, similar hospitals like yours in Missouri, we want to highlight on one on the bigger end, one on the smaller end, to kind of so you could see yourself in one of these. So 150 bed hospital through infectious disease, we had over 150 patients consulted. Most were over 70% were highly complex cases. So again, talking at the level 4, level 5 billing rate. We touched almost a quarter of the ICU patients, and only 4 of them had to be transferred out post our consult. Patients treated have an average CMI of 2.82 versus 1.72, which was amazing. Everybody was so impressed, and they had not thought that they could treat patients that complex locally, and they realized they could, and now they have that much more confidence in keeping patients in that facility locally for across the board. And the real interesting fact here is that we were able to keep over 81% of patients discharged under the mean length of stay after the consult. So not only were we able to increase bed utilization, but we were actually able to do it in a way that reduced length of stay. So they're able to maximize on the impact of that patient staying there. So what does this mean at the end of the day? Almost $3 million in additional revenue for that hospital for just from having remote specialty access in one clinical line. Similarly, for a smaller 50-bed hospital that now has 3 clinical lines under coverage, over 175 transfers prevented over that time period with over 200 patients seen. And that's a huge number, but especially ginormous for a small hospital of that size. It's a sole community hospital. They were excited and it's so happy to be able to keep all the patients local. And they were able to keep over 90% of their high complexity cases. And again, saw the same similar improvements in CMI that they were able to treat on site versus before they were just automatically transferring them out. Over 60% of their patients discharged below mean length of stay, which maximizes again the DRG that they're getting for these patients. And the really cool thing here that we were able to tease out, we saw about a 50% reduction in 30-day readmission rates, which, as everyone knows, that's a huge number tracked by a lot of different entities, of course, CMS included. And it's a great reduction to show so that, hey, we were able to identify these patients, treat the patients, and get them out, get them home quicker, but not just quicker, but in a sustainable manner where they didn't just come back sick again in a couple of weeks. And this led to over $1 million in annualized revenue added to the hospital in that time period. I'm going to turn it over to Anand here to talk about, now you've seen what the impact, what the cost is for not having remote specialty coverage, what the benefit and opportunity is to add that remote specialty coverage. Now Alan's going to talk you through best practices for putting that in place.
Thanks, Mina. So We've talked about teleconsults, and I think to a certain extent, most everyone kind of understands and gets that having specialty access is really important. Telehealth has been around for a while, especially in the inpatient side. So, kind of the question is, why don't we see this more broadly being done with hospitals with specialty access issues? And I think the question right now, the answer is simply it's really burdensome and really daunting to be able to implement a telehealth program, telespecialty program. Right now, there are just a bunch of different barriers that are put in place. And that makes it especially hard for smaller hospitals who don't have the resources to be able to pull all of this together and manage a program like this. So questions around what software do I need and how does it comply with my existing IT? How do we figure out reimbursement? What is the cart that I need? Oftentimes these carts are $100,000 plus, and they do some amazing things. But that can be a huge investment for smaller hospitals to make. How do I manage a panel of physicians and where do I find them? If I don't have them locally, physically, then how do I go out and broaden my kind of geographic search to be able to build a panel of physicians? How do I manage call schedules and fill in gaps when we don't have access? And then all of the different compliance and regulatory issues, whether it be HIPAA, whether it be state regulations, payer regulations, all of those different things are extremely daunting. And so what we've seen typically is that, it's just too big of a kind of lift to figure out all of these different things for hospitals on themselves to do. And that's, a challenge that's there. But what we will say is that I'll walk through some of the kind of these challenges and what are best practices to kind of approach them with. Is that thinking small and getting what access you can is really a great place to start. You can get a lot of value by not having to build up these hugely complex programs that are out there. Getting that kind of advice and expertise into your hospital is really important. And whether you do that through telehealth or not, we believe that it just delivers a ton of value to the system overall. So I'll walk through some of these different challenges and kind of, at least as we've been enmeshed in this space for years now, how we think about, some of these as we've gone through. There's, a general kind of sense for if you're thinking about bringing in a physician and some of the telehealth providers, coming in and essentially charging large fees, fixed fees that account to the same as hiring a physician full time. I think that to a certain extent, what you need to kind of think about in this is think about the overall value. It may seem expensive to spend, X amount for a physician to come and practice in your facility, but think about kind of the value that it's creating. And we've talked about the transfers here. We've talked about the impact to overall care, to 30-day readmission rates, all of these different metrics. They deliver a lot more value than we can think about. And if you don't have access to those physicians any other way, then you should think about it as an ROI system. I think to a certain extent, ensure that you're asking for billing rights or getting credit for the reimbursements here, because as we'll talk about in a second here, there's a lot more movement towards reimbursing a lot of this activity. And we've seen, especially with rural hospitals, they can get pretty good reimbursement rates for these cares, which really works to kind of offset a lot of the cost. And what I'd say is that even if you can't get a telehealth, really think about kind of hiring and or subsidizing a physician, whether directly or through locum. You'll think that it's you're paying for a physician on staff. But it can oftentimes make sense depending on the volumes. The challenge becomes if you don't have full, enough volume to keep that physician busy, then they'll oftentimes turn over and leave, which then creates another kind of cost for you and disruption in the environment. But if you do feel like you have enough volume to be able to keep a physician busy, subsidizing that physician and bring them, even if you're not doing telehealth, we believe really strongly in having this access. And the benefits that it can drive to your facility. I think another barrier is just the issue of having to spend so much to set up the telehealth program before it even starts. As I mentioned before, telehealth, a lot of telehealth programs and a lot of this idea of inpatient telehealth kind of started, 15, 20 years ago. And those, were associated with kind of large, bringing in large panels, credentialing in large panels of physicians, bringing in super expensive software and hardware. I think to a certain extent, a lot of the market has evolved. We've seen a lot of new players, come into the market, including us, of course, but there are others as well, that are figuring out ways to be able to do this in a more kind of modern way from a technology perspective, as well as do it in a way that is much more lightweight on the hospitals. I would just look to continue, if this is a program that you want to do, ensure that you're reaching out and getting reaching out to a broad set of players to get that, because I think you can, 5-10 years ago, it was a 6-figure, amount of effort to be able to start up a program. I think nowadays you can find that you can start one up for much less than that. I think to a certain extent, there's the initial reaction of a lot of small hospitals. What we've seen is that they've reached out to local physicians or physicians that are in, the next town over, 30 minutes away, to kind of set up a practice and come on to staff, at least part-time. I think that that's obviously helpful, but oftentimes we see that the nearest physician is not more than is more than a couple hours away. You see that some of the local physicians, even if they are 30 minutes away, don't have the capacity to do that because they're already stretched with what they have. I think that to think about this, it's just remind yourself it's telehealth. You have the opportunity to look much further out, within your state, even beyond your state, depending on obviously the physicians need to be licensed, but there's no physical requirement for them to be in your state. There is capacity out there. What we've seen is that these specialists want to work and serve, and they actually, have satisfaction over serving communities that otherwise they wouldn't be able to serve. And the other thing which I would say is that getting, natural instinct is to want to get 24/7 coverage for these specialties. You can gain a lot, because a lot of these, what we've seen is over 90% are non-emergent situations in terms of, unlike stroke, for a lot of the rest are non-emergent. They're typically routine consults. And so with that, even weekday days can make a huge difference and really get you 80 to 90% of the value. So it's hard to get, physicians to necessarily want to cover weekends and late nights, but you can get a lot of value for them just being able to cover you during the days, during the week. So in terms of, I think the carts we talked about before, again, I think a lot of the initial rollout of inpatient telehealth was around these very expensive carts and these very expensive setups. And that can be a big burden to be able to, for a small hospital to be able to do. And a lot of those things had just amazing kind of technology, and even the ones today that are very expensive, are almost robots in and of themselves, have just these amazing scopes and peripherals that are there that can drive lots of things. But what we've seen is that even most consults, again, in terms of bang for your buck, can be started up with simpler programs, and it is a way for you to ease into the program itself. We have a number of our hospitals that use iPads on a IV pole with a gooseneck arm. And that works really, really well. And we've seen really great results for it. And you can always start out with that and then figure out if there are, things that are nuances in terms of the types of consults that are being seen that require additional kind of peripherals or more fancy kind of carts to then kind of move up to it. But don't let that kind of be a barrier to starting the program and getting going. And I think to get to a little bit in terms of the setup and disruption, broader disruption to the staff, I think that as you bring in more specialties, figure out ways that you can get either the providers to use the same platform, a common platform among all of your telehealth providers, or work with a provider that offers multi-specialties, because it's really hard and kind of like drives to the next point down adoption if you're having to be able to train on different telehealth program software, all of that stuff for every different specialty, and creates confusion on the floor. And that leads to the last one, which is it's difficult to get really used to program. I think the main thing that we have seen is the more that you can essentially mimic the workflow of a in-person consult with a telehealth consult is really, really important. So you need to ensure that you're integrating, existing workflows as much to the way things are done. Any telehealth provider should be documenting and entering their stuff into your EHR. You should be minimizing the touch points with technology. Technology should be the enabler. It should not be the product in and of itself. And I think the really important is try and work with providers that can minimize the number of, the size of the panels. That really drives to a sense of what we've seen in terms of engagement is when it truly feels like the telehealth provider is another staff credentialed physician that forms a relationship with the hospitalist. That's really important, especially with the smaller hospitals where you have maybe 2, 3, 4 main hospitalists that really drive the care in the hospital. Having that, forming that kind of relationships and those one-to-one relationships are really important. It really drives both kind of engagement as well as clinical value and clinical cooperation. So in terms of reimbursement, I'll give, we'd spend probably 2 hours talking about telehealth reimbursement, even in this narrow space of inpatient kind of teleconsults. But I'll give it kind of a little bit of an overview of where we see things stand today and where we see things where they're going. So what I'd say is that reimbursement is still very complicated. It's very unique to every facility. So it's really hard to make kind of broad terms on what it is. But what I would say is that, we should think about kind of reimbursement as a nice to have to offset costs for these programs and understand that the clear creation of value is being able to improve the metrics, prevent transfers, and improve all of the other things that Mina talked about in the case studies. So as I mentioned before, it's still really hard to predict reimbursement. Right now, it's an extremely complicated set of requirements and standards that are very payer specific. So, you have variation in terms of payer, depending on payer and the originating site can determine whether it's in the ED, whether it's an observation, whether it's an inpatient can drive kind of both coding and reimbursement. Obviously, every state has its own rules and regulations that are there. The CMS rural designation opens up a lot of opportunities. Right now, some of those are suspended, but that plays a role. The service performed in an exact clinical workflow that happened. Was it video, async, et cetera? And then obviously all the temporary COVID emergency rules. So all of that being said, it's really hard to predict what your reimbursement is going to be. But as I mentioned before, and as Mina walked through in the case studies, there's clear creation of value regardless of whether you get reimbursement. And so what we've seen, you can kind of think about it. If you think about that $15,000, that can kind of cover a lot of consults to kind of make up for that cost. So I think just thinking about the broader ROI story is really important to think about. That being said, we have seen hospitals able to offset a good portion of the nominal cost of the program, especially rural hospitals. We've seen them able to offset about 70% of the cost of the program through reimbursement alone. And that doesn't include, what we've seen in terms of 10 times plus ROIs from transfer reduction of metrics improvements, regardless of reimbursement. So I think that, there is opportunities to do this. It just takes time and it's hard to predict. But that being said, with the current state today, payers are slowly trending more towards simpler and more consistent reimbursement. So we've had longstanding rules in terms of for reimbursement here. So for rural designated areas, CMS, has had specific G codes for these specialty consults. So it makes it really easy to code and get reimbursed, and they're quite generous in terms of what they offer. We've seen about half of state Medicaid programs have been reimbursing these consults for a while. And then what we saw pre-COVID was a movement, so kind of 2018, 2019 kind of timeframe, kind of movement towards expanding it and understanding that there are additional kind of services that can be provided through telehealth in the inpatient setting. So there are expanded programs for interprofessional consults, so just doctor-to-doctor communications and some asynchronous kind of workflows that could work in the inpatient setting. There was push for more reimbursement for behavioral health, and we saw kind of movement in state legislation for telehealth parity for private payers. And so those were things that were kind of pushing through. All of that kind of got a little bit disrupted within the COVID emergency. So a lot of, as everyone knows, a lot of restrictions have been lifted and are currently kind of lifted across the board. But I think what more has COVID emergency has done is just opened up the overall acceptance of telehealth as a model for care, especially in the inpatient setting. With D-side, we've seen that hospitals are much more open to getting their kind of experience through a telehealth provider. And more importantly, we've seen specialists who have seen that they can provide a very high level care in these specialty, using specialty teleconsults to patients in these hospitals. So I think there was a general thing that I need to really see and feel the patient, to be able to be there in person, to be able to provide good care. What we've seen is that there are models that can provide that same level of care, and even a higher level of care, because you have more kind of touch points with the patient through telehealth, and easier access to the patients through telehealth by these specialists, and understanding a lot of the value that they're creating is understanding the chart, using their mind and experience to be able to provide good guidance to the attending physicians. And so what we've seen, as we see going forward, is that acceptance, I think, is leading to, pressure to make permanent some of the, or at least extend some of the COVID emergency measures, including lifting that geographic restriction. So as probably most of you know, the CMS rural designation is very specific and oftentimes a little bit constrained. The ability to move it out really will make it more accessible for more hospitals to be able to get access to these specialties through telehealth. And I think that more broadly, a trend that we've seen in conversations that we've had with payers is generally, the sense on telehealth is that if you increase access too much, then you're going to lead to overutilization. What we've seen studies that have been done, our own experience and conversations anecdotally with payers, that they're understanding that not only is there a benefit to the hospitals, there's also an overall benefit to the system overall. So not transferring a patient, means not having to pay a bundled payment again, not having to transfer pay for the transfer and the transportation of that patient, increasing the risks of additional complications with the transportation, as well as oftentimes when you move to a hospital that's in an urban area 2 hours away, that reimbursement rate, the cost of that hospital is 30, 40, 50% higher than what it is in the rural hospitals. And so I think to a certain extent, they're seeing that value. And I think that's huge from the standpoint of if they believe, especially with these specialty teleconsults, that there is not the overutilization concern, then I think you're going to see more movement towards payers accepting and kind of pushing for reimbursement on these things. I think that's all the content. We've obviously spent a lot of time kind of talking at you, and haven't had a lot of content there. Would love to open it up for questions to both me and Mina.
And I'm looking at the chat to see if any come in, but just first of all, I just want to say thank you. That was a wonderful presentation, great information, and really on point looking at some of the stuff going on in our state. It was awesome. Thank you.
Great.
If anybody wants to get a hold of you, to learn more, is this the info at T Squared Inc? That's the best way to get a hold of you?
Yep. And then that number you see down there is our direct number. So you can reach, actually you'll reach me probably if you call that number. And we're happy to answer any further questions, talk about how, if we can go through what specifics are for your reality at your hospital in terms of what the specialty needs are. What we found really helpful for hospitals just to get a sense as you're thinking about it, get a sense of what patients am I transferring out? How many are going out each month and what specialties? And where do I think I could address that? And that kind of will help you highlight what specialties you can most need. Most people know that, but just to kind of drill it home, make sure you're not missing anything in terms of what's causing your transfers and where the gaps in coverage are internally that maybe your hospitalists or your ED physicians would like extra support and help in. And then kind of go from there in terms of evaluating, what can we do? How quickly can we do it? What are our capacities? Again, as Anand mentioned, we see a lot of hospitals starting as simply as an iPad on a stick. And it's more important to get the right team together to make sure everyone meshes together and make sure the workflows work for your team as well as for the remote team, so that it's a long-term solution, not this ad hoc thing that comes and goes. So that includes support with workflows, 24/7 customer support, help with the nursing team and charting and documentation, billing, all of that stuff. So it's definitely a partnership, and you want to look at it that way, and you want to look at it as someone that's there for you to help you as a hospital and as a community pillar, quite frankly, deliver the best care possible to your community. So again, we're happy to answer any questions at any time on what it could mean for you. And if not, like I said, Derek will have a PDF and he'll have it to send out along with the recorded conversation.
And and to note, I'm glad you brought up the assistance with charting and nurses and all that. And, I don't know about y'all's experience, but both my experience with the hospitals we've worked with implementing similar programs, and I actually just finished off the National Rural Health Association, or National Institute for Health, was looking at provider-to-provider telehealth, and I was at their conference a couple of weeks ago. But the nursing support across the country seems to be a really big hit. I mean, it seems to be something that everybody's talking about and kind of shocked by, that even more than some of the providers, the nurses are just loving stuff like this. And I think anything to help our nurses is a huge deal.
Mhm. Certainly.
A quick question. The presentation mentioned utilizing existing programs and services to kind of help integrate this, so it's not such a daunting kind of program to bring in or service to bring in. Previous examples I've heard of kind of following that same structure are things like diabetes management. Instead of introducing an entire new system just for diabetes, it was kind of, what weight classes are we already taking, or having people involved in as far as programs? What are we doing nutrition wise? And can we get that conversation about diabetes into those special, existing services people are already in? So what are some examples of how to start integrating these conversations about specialty care access, or kind of looking at those in terms of the existing programs? Do you have some examples of how to start integrating that for people who this might be kind of too daunting to start with as a whole?
To start, you mean in terms of identifying which particular specialty to start with, or if they have certain patient populations they're trying to bring more services to?
Yeah. What would the starting point be as far as connecting those dots between what they already have and where the opportunities are to start integrating the focus on specialty care and making sure that those things are being addressed as well?
Yep. So the first things first would be, once we've identified, so let's take diabetes as kind of continuing that example, identifying where the outcomes are and where you want them to be, right? So first identifying the gap in the outcomes and what you need to do to get from point A to point B. So once you've identified, hey, we would like to see A1C levels at X, we would like to see the nutritionists more regularly, we'd like to see these kinds of improvements in these kinds of metrics, that we can identify with the specialists and with their primary care physicians. What do we need to do to address that? Whether that is at a consult with an endocrinologist, is that more regular maintenance and contact with endocrinologists, is it just more regular chart reviews of their labs and flagging it earlier? So once you see your glucose rise or your A1C rise, instead of waiting till it gets to 8.5, maybe you flag them at 7. Little things like that. And that needs to be customized for each region, each hospital. But figuring out where you are today, figuring out where you want to be, and then working with your telespecialty provider, or your specialist of choice in that specialty to say, this is what I need, this is where I want to be, how do I get here? And then that conversation will tell you exactly what you need to implement or do on the patient perspective to get there, whether that's more frequent communication, a different type of interaction entirely, a different type of treatment plan entirely, or maybe there's new protocols and drugs. I mean, I can't even tell you how many new drugs have been approved recently for, long-term insulin, short-term insulin, all this kind of stuff. So just staying on top of it is a task in and of itself. So for any specialty, I would say that that would be the key place to start, is where are you today? Where do you want to be? And have that conversation with the specialist, say, how do I get here? And that's the easiest way to integrate.